This conference will now be recorded.
All right, so this particular session is going to be recorded, and obviously, for those of you who are not able to attend, would be able to get a copy of this recording just after the session from the web. So, what we're going to do is obviously continue our journey with regards to completing learning outcome 2 today. And in this particular learning outcome, we are looking at discussing how to understand, basically looking at understanding how to build and lead a multidisciplinary team, or MDT, for the purposes of looking at integrated service delivery. So from our point of view, what we're going to be looking at, in this particular learning outcome is going to go and talk about a couple of things. We look at some of the bits which have been given in the the indicative content. So let me just quickly bring that up. And what I want to do is obviously share that indicative content just to make sure that you're aware that this is, how we are going to be looking at covering this particular content. So just getting a quick grip with looking at sharing that part of the screen. So give me a second. What I want to do is make sure that you're able to, essentially, understand that the learning outcome 2 is more about, building and leading an MDT or a multidisciplinary team. And this would essentially be, let's say, important because it's mostly theoretical, and what we want to do is understand and build on our understanding for the team working model that we did discuss in the first learning outcome, which is Tuckman's model of team building. Now, in this context, what we want to do is essentially just quickly go ahead and discuss what is in the indicative content. So we are looking at understanding strengths and weaknesses, of multidisciplinary teams, a range of things which we want to understand. I think the key terminology that we will be looking at would be what is integrated service delivery. And I have a small video that I would watch, share with you so that we'll all watch it together to understand this particular meaning of the term integrated service delivery, because the whole idea of actually leading, let's say, whole idea of actually managing, putting together, managing, and then leading this multidisciplinary team is to look at providing integrated service delivery in the health and social care sector. So we look at some advantages, disadvantages, or strengths and weaknesses in terms of what are the main reasons why MDTs are formed, what could be the positives of it or advantages, and what could be some of the negatives or disadvantages of it when people work together in MDTs in order to be able to look at delivering integrated service. We'll focus on the second assessment criteria, which is going to be, more or less solely based on understanding team building, leading, and motivating. And this is where we'll be looking at the Dr. Belbin's team building role model, which is the theoretical framework that we need to understand to cover some of the bits in terms of understanding what roles could be assigned, why people are suitable for certain kind of roles within the teams, and then what could be the skills, experience, or attributes that bring to that role and why they are classed in that particular category. So we look at some of the research which Dr. Belbin did, and then he proposed this Dr. Belbin's team roles model is what we're going to study for the assessment criteria 2.2. And then the last one, what we're going to be looking at is understanding how do we lead MDTs in terms of delivering integrated service, in terms of patient care, when we talk about patient care or patient-centered care, or approach, PCA as we call it. And that is what we will do in terms of understanding in the last assessment criteria, which is 2.3. So starting nicely with understanding why MDTs are put together, how they are put together, theoretical part of it, and then looking at how do we lead the MDTs should you be in that position, of interest. Now, looking at the first learning outcome, we did discuss some key terms, which obviously are going to be consistently discussed across this particular unit. And this is basically looking at why do we need multidisciplinary teams and what are multidisciplinary teams. We also looked at some of the key roles which are in the health and social care sector, and I've kind of used a picture graphic essentially to describe all the various kind of roles that we get to see within this sector. Now, some of the key messages that we would be looking at and obviously going through in this particular unit are focused on the fact that MDTs are pretty much a part and parcel of the National Health Service or the health and social care sector, uh, as against any other sector that we get to see and work in. The MDTs primarily are an effective tool because in some cases when the goal to be achieved is greater in terms of the objectives, and a lot of people are required to work on them, then obviously collaboration tends to be the name of the game. And in this case, what we do get to see is that leaders, supervisors, managers at some stage start looking at forming teams which are going to be like-minded professionals who would essentially come with some knowledge, background, experience, and skills to be able to deliver integrated care to patients, so that there are manageable outcomes which come out of that particular delivery. We also look at that sometimes when you look at putting the MDTs together, they require a bit of coordination, and there could be barriers, there could be effective ways of managing these teams, and communication tends to be one of them. And you would generally see that in large teams there are people which are given specific roles of in order to carry out those functions. A simple example of this that I would give is that if you are having a team meeting, there is somebody who normally would be a notes taker, and there will be a manager chairing the meeting, and there will be participant in the meeting. Similarly, of this concept, if we extrapolate that and apply this to the health and social care sector, what we're going to see is that the MDTs work wherein roles are specifically given to specific individuals, and they are quite competent in carrying out those roles. So we will look at that by looking into the theoretical model of Dr. Meredith Belbin and its team roles. And then we look at this approach, why this has become very synonymous with the approach in the National Health Service and in the health and social care sector. And we will be looking at, I'll be probably looking at giving you a steer in the direction of reading one or two articles, which primarily would give you some detailed idea in terms of why MDTs are important and why the integrated, why MDTs are important for the delivery of integrated delivery in terms of service, patient care, for example, specifically in the case of health and social care sector. Now, let's look at a video which I would want to start off with, which is to understand and give you a broader understanding of what is integrated delivery. And this is what I would essentially want to start off with. So let me just share a different part of the screen so that we are able to see this particular video and then listen in to understand this. So let's look at this video, which is primarily courtesy SCIE, and it explains the concept of integrated care and service delivery, and why is it important within the health and social care sector using multidisciplinary teams.
With consultants dealing with a very specific set of diseases like diabetes or dementia or heart trouble, and people have been treated as if they've only got that one disease. However, now the majority of people here over the age of 75 have at least 3 of those long-term conditions, which means they need to be treated as a whole person rather than a series of individuals. So a series of individual diseases. So what that means is that we're asking lots of people who are used to operating and working independently, now working together in an integrated form. And that's what today's about.
So the good practice is that we have a common sense of what we need to do together. So we're not fully integrated, but we're aligning what we're doing. We're creating multidisciplinary approaches, particularly looking at health and social care staff. So bringing together community health services, mental health and social care staff to work and then to take a place-based approach to how we deliver care. So that's one of the good things I would say.
On the issue of culture with our health and social care services, I mean, one way we tried to tackle it right at the beginning was we had quite a big workshop where we invited people across health and social care And we talked about the importance of what we're trying to do to try and get that shared vision, so that we've all bought into the same vision for what we're trying to achieve and the difference we're trying to make. And the way we did that was to look at some key statements and what people thought about those key statements and whether they agreed or they didn't. And we found that there was quite a lot of commonality in that vision for trying to get people discharged as quickly as possible, because there are real benefits for people in terms of their recovery and their longer term health and well-being. So that brought people together. But also within that workshop, what we did was we had people sit at tables for their own organisations. So we have the acute trusts, social care, voluntary sector, community health, each sitting at their own table, and people circulated around them and heard about what their priorities were around what we're looking to do to integrate health and social care to try and work on these issues. And that enabled people to really hear what are the issues for you, for your organisation, and how are they different to my issues for my organisation. And we got that to try and get this shared understanding of the cultural differences. And that combined with, we'd also done a programme where we were trying to develop anyway integration change champions, and part of that was, again, we did some workshops around exploring cultural differences across organisations. And what often came up were actually some of those differences are more about perception rather than reality. And actually at the bare bones of stuff, there are a huge numbers of similarities across all our organisations, and sometimes it's just around the processes being different, and that's something I can work with a lot more.
So as you can see that what we have come across is the concept of integrated care, and I think in the start of the video the gentleman here actually described it quite effectively, saying that why the approach of multidisciplinary teams is important in the delivery of integrated care to patients within the NHS and in the wider community in general. So what we want to be able to do essentially is look at some of the bits which have been mentioned, and then basically look at applying this to this particular learning outcome in general throughout. And I think the first assessment criteria that we're going to be looking at, which discusses this, is going to be focused on understanding the strengths and weaknesses of MDTs and what is their role essentially in the delivery of integrated care. So the role of MDTs is what is being highlighted in this video, and what I'm going to do is essentially now discuss what are the strengths and weaknesses, so advantages and disadvantages of MDTs, which are important in the delivery of integrated care. So one of the first things that comes up is that when we work and we apply this particular approach of MDT, it allows patients to access the entire team of experts when they are looking at getting care, or obviously getting to some sort of diagnosis, or wanting to go into the diagnosis in terms of receiving the care. I think what becomes important at some stages that they get the access to the entire team of experts. So things like when you are in a hospital and obviously wanting to undergo a surgery, or say you need care, then you have the access to the entire team. You have access to consultants, you have doctors, you have practice managers or practice nurses, essentially clinical nurses, you have healthcare professionals, and other professionals within that remit who are then able to provide you the best possible treatment that is currently available to solve or rectify the condition that you have. It could be an example taking people receiving care in COVID, the people receiving care especially for cancer treatments or other kind of let's say serious diseases like this consultant mentioned, diabetes and heart conditions. And in those cases, you need to be really looking at getting access to the entire team of experts before undergoing any operative procedure. The second advantage tends to be, or strength of the MDT tends to be in terms of service coordination. So what we do get to see is when people are working together in multidisciplinary teams, trying to provide integrated care, the commitment levels, and the level of commitments that is seen is generally, leading to greater efficiencies and obviously coordinated approach. And in this case, this framework of uniformity allows the patient to receive, treatment to the standards which have been defined. And this allows also a speedy recovery to happen in some cases after the patient has received palliative care, say, for example, undergoing some sort of a procedure or, essentially, receiving some sort of a procedure. So when we talk about this particular approach, it looks at providing improved coordination because of the accessibility of the team working to deliver this service to a particular patient. Now, sometimes you also see that one of the advantages tends to be, or strength tends to be, that it expedites referral process. So when we see, this, if you look at imagining that, if the GP surgeries were working differently or not connected with some sort of a central medical database or records that we have in the National Health Service, it would have been very difficult for somebody to see, as a GP, I would see a patient at the surgery, and then if I had to refer the patient for further investigations to the hospital or to A&E, it would have been very difficult to translocate all the records and, observations and have that being sent over. So when we look at this process of referral, which tends to happen wherein if this is something that cannot be done, then in some cases, if you have to refer patients across to specific areas or people within the practice or within the larger community, which is the NHS, you would generally see that for specific treatment, referral as a process works best because there is a seamless integration of the departments working together to be able to, provide this particular service without, exercising any delays or delays in the treatment of the patient. So the referral process seems to be seamless. If you are diagnosed with a particular problem, the GP would straight away refer to your hospital. Obviously, you'll have a consultation. There will be steps put in place to ensure that you are able to get the service promptly, and obviously, you have the maximum chances of your health being restored to, or your health improving to the standards which is required. And if it was a disease or a condition that was diagnosed, then you are rid of that condition or that diagnosed with the proper and timely diagnosis, because the referral process is seamless. Then we also look at the avenues for service implementation, which is basically saying that because of the MDT approach, patients are able to access multiple resources and people within different departments and organization, and this allows the resources to be effectively put together to use to be able to bring out or provide care for the patients. And at the same time, what we also do get to see is that this approach allows patients to be able to access those resources to be able to receive immediate care. One second, let me just do one quick search. So let me just have a quick yeah, and then the other bit which I was trying to get one or two learners online. So the other bit that we also see as an advantage is that it allows patients to create goals for themselves. That is what I mean by that is that in some cases you would see that in some cases the patients would be able to set specific goals, and this is where I would kind of bring in the example of I would say say for example, if you've undergone some sort of care and you've had a bit of a say for example an operative procedure done, then in those cases what tends to be the case is that in order for you to recover fully, what will happen is that at some stage you would need different people to be able to support you in order for you to get back to your say normal self. And in those cases you would generally see that when we talk about palliative care, we talk about physical, emotional, and practical support which is provided to people with terminal illness. And in those cases you generally see that if you have to set goals, specifically in the case of improvement goals or goals that the patients need to be able to hit on a daily, weekly, monthly basis, they would, be very well coordinated and designed to be able to make them effective under the approach of the MDTs. A simple example that I would give here is that we see obesity as a large problem within most developing and developed countries, and we do get to see that if people are to lose weight or lose weight and have a controlled diet in terms of nutritious diet, but at the same time lose weight, they need to be able to create so when, for example, you're referred to by your GP to a wellness clinic or to a clinic wherein you would be undergoing, let's say not treatment, but undergoing specific, let's say you'd be receiving, a specific advice to be able to reduce weight, how to lose weight. Then in those cases, the patients would be required to create specific goals which they can work on a daily, weekly basis and achieve those goals to be able to reduce the overall, obesity or lose weight essentially. So there, in those such cases, you would see that the multidisciplinary team approach tries to encourage, the wider members of the community, family in particular, for participation, and this allows the patient, essentially to hit those goals, and that is where you would generally get to see this, being done on an advantage or as a basis wherein it is considered as one of the strengths of the MDT. Now, when we talk about some of the strengths and advantages, we should also be looking at some of the disadvantages of the MDT approach. Now, sometimes you get to see that some of these disadvantages could be that, the MDT approach tends to create a bit of pressure or a stress, I would say time pressure essentially, in some cases when we look at a lot of goals and objectives which have to be met in order to deliver integrated care. So sometimes we will see that there are modifications required in the treatment plan, and these modifications create or changes which are done essentially create stress and pressure, time pressure with the staff which is involved in delivering this integrated care. So a simple example of this could be that sometimes you look at this working hand in hand with a bit of a collaborative approach, but also you get to see this that it creates a bit of a pressure on the team, because if you have a number of patients which are waiting to receive this treatment, and a case in point that I would give you as an example would be that during COVID pandemic, what we've seen is that a lot of other illnesses, patient with other illnesses have got left out things, and there's a backlog which has got created. So what has happened is, although the entire team was focused, and the whole NHS was focused on dealing with the pandemic, but this has meant that modifications to the treatment plan, or modifications in the sense postponing of treatments for other patients which are termed as non-critical illnesses were because of the shortage of ICU beds or ventilators and things like that was done, and that has created a bit of a backlog and in general a time pressure in terms of providing these services at the NHS. And this is considered as a disadvantage, or as a weakness of multidisciplinary team, because the whole approach was focused on dealing with the pandemic, and that is where some of the other patients have got left out because of the postponement of operations and procedures which were supposed to be carried out. The second disadvantage we do get to see is that different team members come from unique backgrounds. So sometimes cultural differences, communication can lead to communication issues, can also mean that people coming from different backgrounds and different skill sets and different, let's say, domains from when they are put together into a team, and some of them would, be looking at obviously, not working well within those teams because they feel that they might have more experience or have had more experience because of their knowledge, skill set, and the academic background. And in some cases, what you generally get to see that it creates, maybe a bit of a reverse, it reverses the, main aspect of putting multidisciplinary teams together. So here you would see, people with different backgrounds from different cultures coming together with different number of years of experience, and they would feel that some of them have not been dealt the right hand in terms of being put together into very commissioner or beginners team, and have not been given additional responsibility, and because of which you would generally see challenges can arrive in terms of working. The other weakness or disadvantage tends to be that you require frequent collaboration, and the collaboration needs to be effective in order for it to be able to work to provide integrated care. So sometimes you would see that if there is a large team and a lot of people are working towards achieving a particular goal, you would normally see if communication is not done and used as an effective medium to send information across, it sometimes does happen that not everybody is singing from the same hymn book, and in those cases it could have detrimental effects in terms of the integrated care which the team is responsible for providing. And you generally get to see this happening primarily in places wherein sometimes we see in the news that the trusts are being investigated because of so many number of deaths or so many cases which have arisen, and that is primarily because of negligence or large teams not being able to collaborate, and that would mean that sometimes a lot of time is wasted and spent on meetings, and it does not lead to some sort of conclusion or meaningful conclusion. We also look at resources. Sometimes when there are lots of people within the teams, resources can be constrained, can become a constraint, and this tends to have an effect on the the delivery of integrated care which the team is responsible for delivering. So NHS, we do get to hear that NHS is cash strapped, NHS has a lot of pressure on resources, and sometimes having large teams or complex teams which basically are involved in the delivery of integrated care, specifically within the PCCTs, trusts, and things like that, you would generally see that availability of resources tends to become a weakness when you have large teams and they compete for the same set of resources to be able to deliver on the goals. And then you look at indecisions or incomplete decisions which happen without complete information. That means sometimes you would see that decisions are difficult to be, they are difficult in terms of reaching because the team has different opinions. The members in the team have different opinions, background, experience, and they come across and obviously put some of these points across quite strongly, which means consensus cannot be built in some cases, and decision making can be delayed, and in those cases obviously it has a retrospective effect on the integrated care or the care which is required to be provided to the patient. So sometimes you would see decisions are taken with incomplete information, decisions can be delayed, or decisions taken do not have, or the members taking the decisions do not have access to the full information, and in those cases the decision taken sometimes can be detrimental from a point of view of providing care. Now, as a end result of understanding the strengths and weaknesses or advantages and disadvantages of MDT, what I would suggest is, as a bit of an introspective, if you think about your own place of work and see what does the term integrated service delivery mean to your organization, and then pick out an example and discuss that for the completion of task 2.1. And I think that would give you a sense of perspective and also help you understand the meaning of integrated service delivery and integrated care and what it means at your place of work with regards to your role and responsibility that you have within the organization that you work. Now, going across to the second assessment criteria is this particular criteria is very closely linked with task 1.2, where it talked about analyzing skills and techniques required to build cross-functional, cross-disciplinary teams or multidisciplinary teams. Now, in this particular task, we are looking at discussing basically looking at doing an analysis of the skills which are required to build, motivate, and lead multidisciplinary teams. So essentially, the focus is primarily on understanding skills required to build MDT. Now, what I would suggest is if you go through this particular article, which is uploaded on Moodle, and this particular article, which I will show you in a second, talks about essentially discussing let's say what are the key factors which make the MDTs successful. So let me just quickly show you for a second in terms of what article that I'm referring to. And as you will see that this is something that you'll recognize that we used it in the first learning outcome. And this particular article, talks about multidisciplinary teams and then what are the skills required and what are the factors required which are essential for the team MDT to be successful. And if you study each of these factors, when we talk about the skills required to build a team, that means if you are putting together an MDT to work and take over, take on a particular objective, what we need to be very clear about is that people working within the health and social care sector or within the National Health Service, mental health care service would need to know very clearly things like what is patient-centered care, what do we mean by physician integration? That means doctors and GPs and consultants. Why do we need to have shared goals and objectives? Why do we need to have shared information across the board, which allows us access to patient records and patient data so that appropriate care could be provided, duplication of information is avoided, and it also leads to less of time wasted because of shared information across through patient records. And then we need to be looking at the culture of collaboration. We need to be looking at the background in terms of the culture and obviously a shared decision-making process. So some of these factors that I'm talking about are very important in terms of understanding, in terms of building our understanding to the skills which are required to be able to essentially lead or build a multidisciplinary team. So when we talk about this particular aspect, if I go back to the presentation, it is quite clear that when we talk about this, we are looking at the examples of the team coming together, the team coming together, having these shared skills to be able to provide integrated care. Now, because we're talking about skills and we are talking about team roles, what we also need to understand is theoretically, from our point of view, also understand what do we mean by the team roles. So when we talk about team roles, specifically what I'm going to be looking at is Dr. Belbin's model of team roles that he came up with. Now, he is a scientist which is quite renowned in the sense that he's the one who basically came up with this particular theory when he did his research to understand that when people are asked to work in teams, they can be grouped together in specific roles on the basis of three broad categories. So we generally see people when they are brought across into teams, they generally tend to be having three different qualities. So we will look at people being brought into the teams which are going to exhibit or be a part of the team wherein they would either be thinkers, they would either be doers, which is action, and in some cases we also look at people who are going to be essentially social. That means they will get on with any bit of work which has been given, and they will play their part in terms of working within the team to be able to deliver that objective. So when we talk about these roles, he came across and he classified these roles into three different types, and these three different types were action oriented, thought oriented, and people oriented. So could also be said that they were thinkers, doers, and essentially people who would get on with other people from a point of view of different kind of roles that can be given to them within the team. So if I look at broadly classifying and talking about them, there's a handout which I'm going to share with you, which will be through the Moodle, and it talks about the roles and the background with which he came across, and he basically specifically studied the personality types of individuals during the experimentation that he did. He came up with these models, and then he looked at the common elements which could be classified together and then color coded. And this color coding, essentially came across in these three different types of roles that we get to see. And he defined each of the role in a bit more detail to talk about the three types when we talk about action oriented. So when I say he came up with three different types of roles within people who are classified as action oriented, as implementers, shapers and complete finishers. And he then described some of the personality types, within these roles, to give us some idea and indication in terms of if we have a person who is classified as, an implementer, then in those cases, these people tend to be more systematic. They will apply common sense. They are loyal. They are structured, and obviously some of the characteristics which were then governed out of the personality types that he studied and the models he studied are relevant to helping in the recognition of once the team is built, what kind of role the person would end up taking within the team, and then perform accordingly to be able to help the team achieve that particular goal. Now, some of the questions which obviously got answered by this particular model that he's proposed and is now widely and globally accepted. He answered questions like, what can be gained by identifying people's role within the team? So in order for him, he came across and he clearly propagated the idea that in order for people to be effective, they have to have been given a clearly defined role, which has both expectations and understands and takes into account their own tendencies and preferences, and this allows the let's say the team leader to put them into and assign them different roles. Now, can the roles in the teams change? Yes, the roles in the teams can change, and the profiles which are assigned to individuals within the team roles can definitely change depending on the circumstances and the situation. And certain people within certain roles over a point in time, after gaining experience and obviously being a part of the team and delivering that function or that role time and again, over the years can develop that experience, and then in those cases it is up to the team manager and the team and the manager in particular to be able to move them into a more appropriate role, which is going to be taking into account the skills attribute and the experience the person has gained. And a simple example of that could be, as you gain experience while working within the organization, you move up your career ladder. That means you get promotions and you get promoted, you get higher responsibility, and that is where we get to see the roles changing. Now, one of the questions which came across in his research, because he was a psychologist and obviously he looked into the various personality tests and kind of collated all the personality types by studying the personality models, in particular the Myers-Briggs personality models that were proposed. And he then came across and one of the questions which was asked is, what is an allowable weakness? So do we have team members or people within the team always having strengths and weaknesses? Could there be members in the team which are primarily going to be weaker than some of the other members, and could that mean that the overall goal could be jeopardized? So in some cases, in order to address that, he basically came across with the term that yes, team roles can have an allowable weakness, which means at some stage, there could be people working within the team and could be, contributing to the achievement of the overall goal and objective, but that would be commensurate to the amount of pay they get, for example, or based on their performance and the contribution to the overall objective, they could be then classified and assigned roles, within the team. And that would allow allowable weakness or members within the team which come in and do their contribution and accordingly are compensated basis their performance. There were some other questions which came across in his discussions and while he proposed the model, which was, can a team role be sacrificed? So he came across with a category of 9 different roles, as we get to see, and they're classified across these 3 broader categories of action-oriented, thought-oriented. So one of the questions which came across was that can one of the roles within these categories be compromised or sacrificed essentially? So in certain circumstances, you generally get to see that you form a team and people will, take up a role of a coordinator, somebody who's a shaper, somebody who's a planter, somebody who can do evaluation, can do critical thinking, somebody who's a doer. You could look at, somebody who's doing researching, and they could be good at communication, coordination. Some of them work just in the role and are supportive of it and can work as a team worker. Some of them are more in paying attention to completion and the achievement of objective. And in some cases, you would have people who probably at the higher level would be a specialist because they are highly focused, they have knowledge, capability, and they are driven by professional standards to ensure that whatever is being given out as an objective is achieved to these standards. So in the case of health and social care sector, the CQC standard or the registered manager within the care home or the old age home is the person who's responsible for ensuring and can be termed as a specialist, is responsible for ensuring that all compliances and standards on the quality side are met. So in this particular model of Dr. Meredith Belvin that he came up with of team roles and descriptions, he was able to cast, fulfill that there could be 9 different types of roles in a particular team, and individuals can be given these roles depending on their skills, their strengths, their background and experience. And this, important step of recognizing their ability by assigning them this particular role was quite important, because this would then allow the team to be able to achieve the overall objective. So for this, in order to make sure that you are able, we are able to understand this in a bit more detail, what I would also do at some stage is share this particular, handout, which will be up on Moodle. And this particular handout, essentially would be the Dr. Meredith Belvin's, team roles. And this handout will explain in a bit more detail, why it is important for us to analyze the skills and then build the teams accordingly, which are motivated to be able to provide integrated care, as far as the health and social care sector, or in, this multidisciplinary team approach is concerned. Now, let's quickly go across to the third assessment criteria, which is talking about, the bit in terms of explaining how multidisciplinary teams can be led to deliver an integrated delivery as far as the care is concerned. So let me switch you back to this slide, and this is where we will look at this. So when we look at, in the first instance, we've understood why and what skills are important, and what could be the strengths and weaknesses of the multidisciplinary teams. In the second outcome and the assessment criteria, we've talked about skills which are required to build these teams and to keep them motivated. And in the last one, what we want to understand is how do we lead these teams? If you're in that position wherein you have to provide leadership, then how do you go about providing leadership in a way wherein the MDT can be effectively used to deliver integrated service to patient or patient care, in this case, specifically within the health and social care sector or within the NHS. So a lot of studies, have been done on leadership, and leadership is a very, very, let's say, a topic which gets discussed very often. And, there is no particular benchmark or a parameter to say that leadership, this kind of leadership is effective. There are, I think, 21 different models of leadership. We talk about participative leadership, laissez-faire, autocratic, democratic. We talk about situational leadership, transformational leadership, transactional leadership. There are lots of different models which have been proposed over the years, but there's not one particular model which can, answer this particular question of, how and what could be the most effective leadership model to look at integrated service delivery within this within the health and social care sector. So it's a very controversial area in terms of research in the area of social sciences, but let's put it into a bit of perspective because we are studying it from a perspective of MDT, multidisciplinary teams. And if you are in charge of a MDT, how would you lead that team to ensure that the team is able to look at delivering on the objectives which are set by the management? So some of the objectives could be objectives responsible for making sure that the patient care is delivered to the standards, and these standards are then in turn set by CQC, which is the main body looking at maintaining standards and defining standards in this sector. Now, when we talk about the integrated care, there are certain elements to how this care is delivered and who receives it and what role they play. So it is depicted on this particular diagram or a flow chart. So when we look at integrated care, you have a provider, you have a policy maker. In this case, it is CQC, or a regulator, which is CQC. The policy maker could be the government, in this case, which is the National Health Department. You look at provider, which could be hospitals, GPs, surgeries, or people essentially working within this sector who are working with the providers, PCCT trusts, GP surgeries, community centers, and others who are delivering this, from where the delivery of care happens. Then you have care professionals, or people or professionals working within the sector. There are evaluators, committees. Sometimes we see trusts, which are set up, which basically look at doing research and compiling data, feedback, and surveys which are done, and compile them to look at benchmarking it against the standards, and they would be termed as evaluators. So the King's Fund and the organizations which basically look at evaluating the service level, agreements, and obviously how delivery is done. You look at the wider community which participates in the delivery of care. You have the service user and carers, essentially people who are effectively at the front line delivering the care. And in some cases here you would have providers who put out information, in terms of how care can be delivered, and then people who are managing these standards or basically looking at coordination. Sometimes we call them as practice managers within surgeries. We can name them as, or call them as, management within the PCCG trust, and they would be all a part and parcel of how integrated care is delivered to patients. Now, when we talk about leading an MDT or a multidisciplinary team, this process is not very different from the PDCA cycle that we've studied in management, which talks about plan, do, study, and act. And when we talk about the MDT process and the leadership which is required to be delivered across multidisciplinary teams, you generally see in our sector, we basically talk about preparing, assessing, diagnosing, planning, treating, and evaluating in order to make sure that the leadership is effective. So when we talk about leadership within the NHS and health and social care sector in general, what you generally get to see is that the people who are in that position would be looking at preparing their teams, would be looking at assessing their performance. At some stage, they'll be looking at diagnosing problems or problems which arise during the course of working. They would plan ahead, and if there are bits and pieces that need to be changed, tinkered with, or essentially adapted, they would look at them, treating them by looking at corrective action plans, or CAPs as we call them. And then towards the end, once the goals and objectives are agreed and achieved, they will do a thorough evaluation to ensure that this it becomes a process. And if some of these similar situations are faced in the future, then there is a structured approach which is adapted and applied in improving these clinical areas or clinical processes, so that the integrated care could be provided to the patients. Now, there is an article that I would ask you to read rather than me go through it through the PowerPoint, and this would explain this six-step approach, or the 6 phases approach as we call it. So if I just maybe quickly bullet them, so that this is the 6-phase approach that we are talking about. And this article, which basically talks about this cyclical process of how continuous improvement is put in place in order to ensure that integrated service delivery happens within the NHS and the healthcare sector in general within the UK, is very nicely depicted in this particular article. So what I would suggest is to go through this particular article, which I'm going to show you in a second, and the 6 phases that we need to look at. I would encourage you to go through this in order to build your understanding on this. And this article is something that they will also be put up on Moodle. So I've taken the diagram from this particular article, and it says multidisciplinary team working. And then obviously it's a case study which has been done in one of the productive community hospitals of NHS, but it very clearly defines and describes how to lead and lead a MDT which is able to basically deliver on the objectives of integrated service or patient care to patients which are receiving care at the hospital. So this 6-phase process is actually explained in this document quite nicely, and I would suggest that you go through this in a bit more detail, which will allow you to complete this particular assessment criteria 2.3. So I hope today's session has been useful, and a copy of this recording along with the presentation is going to be made available on Moodle shortly. And if you have any questions or queries, I would be more than happy to take them on, and obviously look at some of the references that I put in, and there are some good articles that you can go to for getting a bit more information with regards to the second learning outcome, which is building and leading MDTs to achieve integrated care and service delivery. I'll catch up with you in the next session, which is going to be next week, Monday, same time. And until then, thank you and take care. Bye for now.